Hi, everyone. It's me, Dr. Gege. Welcome to Chats with Dr. Gege. In studio today, I have my colleague and friend, Dr. Sibongile Mbatha.
Hello, everyone.
So I call her Bongi,
Mhm.
but to everyone else, do they call you Dr. Bongi or Dr. Sibongi?
I actually say Dr. Mbat.
Dr.
I know it's very formal.
It's
I've
okay.
tried Sibongile Bongi, but it's because I guess, you see kids and the parents are like, Dr. Mbat.
Ne?
Yeah, so,
Yeah.
yeah.
Okay. So um, I'll call you Bongi
I'm
for,
easy,
right? Yeah.
yes.
But so Bongi is a pediatric neurodevelopmental specialist. Ne?
Yep.
I was like playing with it like neurodevelopmentalist or but I think that
That's fine, yeah.
that's
Developmental pediatrician
mm-hmm.
or pediatric neurodevelopmental.
Okay. So why I invited you to come in today, and thank you
Mm.
so much for gracing me with your time.
Pleasure.
I've been trying to we've been trying to
We've been
align
trying to
schedules.
align, yes.
Is because I really wanted us to come and have a chat about autism.
Okay.
I just think it's one of the most misunderstood conditions. I think it's growing in popularity.
Yeah.
I think the awareness around it is growing. And I've also had a lot of questions around it.
Yes, yeah.
Yeah. And also, I also feel as a pediatrician, I don't feel like I know enough to support my patients with
Yeah.
other conditions that I normally treat who also happen to.
Yeah.
Yeah. So I think we can start with definitions.
All right.
So you can tell us what autism is, and then you can also tell us about the politically correct or the kind ways of referring to it or people who have it.
Okay. All right. So thank you for that. And I think your questions are all very valid. Let's start off with the definition. So, autism spectrum disorder, that's what it is. Some people say it's ASD. It is a developmental condition and it affects two main areas, communication and socialization. So, in the diagnosis, you've got to look at three things under communication, and then there are 2 out of 4 things under the socialization. So, if the child meets those criteria, then we say they've got autism spectrum disorder. So, the communication is understanding just nonverbal communication, so waving, understanding facial expressions, pointing, all the communication that we normally do in a social context without saying words, they would struggle to understand that. They have difficulty with relationships, so understanding a relationship that you can't do certain things with people who are not family members, but for them there's no like boundaries. They'll kind of cross those social boundaries, and just deficits in communication. So late acquisition of words, or you start off with words, then you lose them in the first year of life, and you can later on have more words. Others, though, don't develop speech. So that's about a 30% of people who are on the spectrum. And under the
30%
socialization,
of them don't have speech.
yes.
Okay.
So if you look at all the population with autism, about 30%
don't.
may start off with speech and then lose speech, and then 30%.
We'll come
yeah.
back to that because I think that's the part I don't understand.
Yeah.
Okay.
Yeah. And so the other 30% will probably have words, be able to say some phrases, but not full sentences. And the last 30% will have sentences or fluent speech. Where the child falls, I can't tell from an early age. And as they grow up and become adults, it can change. So they can start off with no words and then have a few words and then sentences. Others remain the same, and others just stay at the single words.
Okay.
So it's different for different individuals, and that's why it's called a spectrum.
Okay.
And then you asked, how do we refer to them?
Wait. Sorry.
Okay.
You said communication
And
and
socialization. Yeah.
So socialization is it is related to communication,
Mm-hmm.
but is it because they don't have the concept of like definitions? Because we define all these roles, right? Like mom, dad, teacher, and therefore I know I can trust, or stranger, or what is it about the socialization?
So I think it's not the defining, it's how they understand social cues. So these are things that we would assume it's not taught. You just learn it.
By observing.
Yeah, by observing and seeing, you take it in. Children will understand if I go to church, guess everyone's quiet. Mum has said, shh, to me, I must keep quiet. An individual with autism, you'll say shh to them and they may just carry on making that noise. They don't quite get that. Or so the social context, they can miss these social cues that we take for granted so easily, that when you talk to people, you've got to make eye contact. They will be looking everywhere except at the person, but they could be talking, or that my facial expression matches exactly what I'm saying. For them, they can have no facial expressions that go with what they're saying. So their understanding of those social cues, and I think that's what frustrates parents a lot, because you always want your child to kind of fit in to this beautiful box and conform, and now you've got this child who just does not fit in. Yeah, I don't want to wear clothes today. I really don't want to wear shoes. I don't feel it. Sensory things, I don't want to sit down. I want to scream and shout. And it's not that they are misbehaving, or it's just the way that their social understanding is slightly different to ours. Yeah.
All right. And then, and then how we refer to them?
All right. So how we refer to them actually differs. So we have individuals who are on the spectrum, who are verbal, and they advocate for themselves, and they'll say nothing about us without us.
Okay.
Right. So they say actually you need to ask the individual with autism how they would like to be referred as, whether they want to be called as an autistic individual, an individual on the spectrum, or a person with autism.
Okay.
So if you can, ask them. Otherwise, I think it would be correct, we refer to it as autism spectrum disorder. So it would be an individual with autism spectrum disorder. But whether you say autistic individual or individual on the spectrum, I think that depends on the individual. Yeah, so if you look at the advocates who are themselves individuals with autism, they will say, you must ask. Some people prefer to say, I'm autistic, I have autism, I'm on the spectrum. Yeah, so it's difficult.
Yeah, I think, I don't know how I feel about titles. Okay, this is unrelated just to what our topic, right? But I just mean in general in the world. The pressure now on society to have to put specific titles for specific people, which are different and unique, and the risk of then people taking offense or saying it incorrectly.
Yes.
I just feel like, gosh, we've always done things one way, and then now for each individual, because now I could just decide, okay, now with my ginger hair, I don't want to be referred to as I don't know what, but you must refer to me as ginger hair.
Yes.
Yeah. So I do want us to not be insensitive and politically incorrect.
Yes. So I'm also trying to be careful about how I word what I say. But we've got to give the facts though, regardless. So that more people will have the information and at least know. Yeah.
So do you think that it's becoming more popular because of the internet and social media? Or do you think that the incidence is going up?
So that's very interesting. And the incidence is increasing. So when I started, I think around 2013, it was 1 in 68 individuals, according to the CDC, that had autism. And now in 2023, I think the last stats that were done is 1 in 34 individuals. That is a lot. So the question is it increasing because there's now increased awareness? So people are going to get a diagnosis, and that's why we're seeing the increase? Or is there something truly genetic that has been woken up, if I can put it that way, to say that there is something in the environment or whatever that's making autism more prevalent? Is it the fact that now they've changed the definition? So before, in the DSM-4, it used to be pervasive developmental disorder. And then they went to DSM-5, and then they did autism spectrum disorder, where all the individuals who were before classified as Asperger's or your high-functioning autistic individuals were then included under this umbrella term. So is there an increase because now we've included everyone where previously it used to be
different categories,
categories, but now they've realized they're actually all just probably on the same spectrum. So yeah, there could be many factors why it's increased, but I do believe that, especially since after 2020, we've seen a lot, and not just an increase here locally, in Africa as a whole and in the world.
Oh, wow.
So the question is why? Not sure. But there's definitely an increase.
There is an increase.
Yeah.
So you brought it up. I was going to ask, is it Asperger's or Asperger's?
Yeah, tomato.
All right, great. Yeah. What is that? How is it different to autism, or is it just another point on the spectrum?
So it is on the spectrum. So individuals with Asperger's were classified as high functioning. So individuals who would have gifts or certain talents that they were good at, but struggled with that communication and socialization, but were brilliant at maths or reading, or had fluent speech, but still had all the other symptoms of autism. So that is what Asperger's is or was. And even though now there's still autism spectrum disorder, there are some individuals who prefer to be referred to as having Asperger's than being on the spectrum. And other individuals don't like the term high functioning, because then is there a low functioning? Is there a medium functioning? What do you mean when you're saying high functioning? I still struggle with so many other things. So it was all that nomenclature. So it was easier to just say it's autism spectrum disorder, include everyone in there. And then when we look at it, we then classify the levels, which is the level of support. So they'll say level 1, level 2, level 3. Level 1 means you need a minimal support, substantial support, or very substantial support being level 3. So that just means how much support
you need. Level 1 person will ultimately be able to live on their own, possibly work, or even...
Most likely that, their symptoms don't impede too much on their function, whereas someone who's level 3 needs a lot of support, and they may struggle with living independently. But also, sometimes the levels don't correlate with their intellect. So their intellect can be completely different. Don't assume if you're level 3, you have intellectual disability, and don't assume if you're level 1, that means your intellect is normal. It's about the amount of support you need. So the intellect, you can have someone who needs a lot of support, but still be very clever. And you can have someone who needs minimal support, but intellectually they have intellectual disability.
So can you define the support that you are saying, because I would just assume that a clever person, I don't know now, what kind of support do they need? Like to remember to,
So
I don't know.
remember, if I'm clever, I could be reading, and I started reading at the age of 3, but I still can't engage in a conversation.
Okay.
I can't tell you what I want when I'm hungry. I can't tell you, but I can read books. I can read an encyclopedia. I can solve maths problems. I can draw. I can
But
do
someone
all
has to
these
make sure
amazing
that you're
things. But
fed, that
yes,
you...
I'm not aware of danger. I can just run out in the streets. I have no stranger danger. So the support is very different in terms of that. And it's in the DSM-5 criteria. When I first learned about it as well, I thought it was, level 1 means it's clever,
Yes,
level
for good.
2, level 3. No,
Okay.
not like that. It's about the support that they need. Yeah.
To live.
Yeah.
All right. And then we once discussed how you and my husband enjoy watching The Good Doctor. So where would you classify Sean? If, like, I'm just thinking if other people have also watched it. So he's a
Yes.
doctor.
He's a doctor.
He's even specializing. He's a surgeon. So
Yes.
he's very intelligent.
Yep.
But the social cues are like...
They are low.
They are low.
But he's able to live independently. Yes, he misses out on the social cues, needs a little bit of, so you probably say they would call him Asperger's. And then
Okay.
his level of functioning, because in society he's okay, except missing those social
Yes.
cues, would probably be level 1 support.
Okay.
Yeah.
Okay.
Yeah.
Yes. All right.
Still level 1. He can
Yes.
still kind of engage in a
Yes,
conversation,
yes.
but he still needs to take himself back to say, what did you mean by that? But,
Okay.
he's there. Yeah.
All right. Cool. So now, children,
Yes.
when can we suspect it? From what age can we suspect it? Because a 6-month-old is not really saying anything. So what's the earliest age that we can start to say maybe?
So I think the suspicion, mom usually suspects from very early on. A 6-month-old, when you call them, you go, Bongi. They'll look.
Yes.
They've recognized. They've been on this planet for 6 months. People have been saying this name. They realize that it's their name. But there are some children who at that age will not respond, will not turn to look at mom, will play just with not normal toys, but like the edge of a bed, or interested in mom's earring or whatever. So mom will suspect it. But to make a diagnosis in that first year of life is quite difficult. So I think us as doctors, especially if you have a lot of experience, you can make it when they're around 2 years of age and just before 2 as well, if you've seen a lot of children. So I think in the second year of life, in terms of diagnosis, you can. But mom will suspect it much earlier because the usual language development steps are not there. Responding to your name. The smile might also take a long time to come because the eye contact is not there. Mom will say, this child is focused always on my buttons or what's around my breast area, doesn't look at me in the face or give me eye contact, always playing with things in one way. But remember, as we said, it's a spectrum. So there are those who develop normally in the first year of life. And then when it's time for the words and the language to develop in that second year of life, so they may say their first word, mama, dada, but at the end of 2 years, they may lose the words that initial... they had. Yes. And that's when mom will say, this child used to say dog, cat, or count, or say mama, and now they don't anymore. That is a big clue. A big clue. So if they have regression,
that is
of that language,
really quite frightening. But that makes me feel like then now as a doctor, like there's a part of the brain then that's affected. Like they surely, if they did whatever scans, and you know how some scans things must be brighter and whatnot. Is it the speech area? Because then I feel like it's the speech area and the is it the frontal area now for emotion and
So you're asking a difficult question, but yes, it is a neurological condition, and it's more about the neural pathways. So I hope I'm not wrong here, but here we go. I'm going for it. Right. So in the first 2 years of life, we form neural networks when we are learning. So as you're learning language, every day you're forming new connections. And I don't know, I forgot the number, but millions of connections a day before the age of 2 that are formed as you're learning new skills. And then at around 2 years of age, a process of pruning comes in. I'm sure you remember it slightly. So pruning is now you've formed all these neural networks. You need to start forming stable connections and proper pathways. So the pathways that don't get used, there's that pruning process that happens in the brain, and those pathways are cut. And the pathways that are used all the time, they are strengthened. Right? I'm trying to simplify it. Yeah. They are strengthened. So they say that in individuals who are on the spectrum, that pruning process doesn't seem to quite happen normally.
It's not organized.
Yes. So if I give an example, and I love giving this example when I'm explaining to parents and students, is looking at how would you go from here to Cape Town? There are many routes. Okay, so we're talking in South Africa, but you can take the N1, you can go via Durban, you can go via Free State, but there are many ways to get there. But if you want to get there the fastest way, then you would take the N1, right, down to Cape Town. But if you went the scenic route via Durban, Eastern Cape, it's going to take you a long time, but the message will eventually get there. So if you have many pathways to reach a point, when you want to send a message from the brain, let's say, to another part of the body, but all these pathways have not been pruned, the message might never get there, or it might get there after a very long time. But essentially, if there's that pruning process, you get strengthening of these pathways, and then you can learn and develop skills and sharpen your skills. So sometimes you'll find an individual or on the spectrum, you may say to them, hello, and they don't respond. And then the mom will say, when they got home, they were saying, hello, doctor. Hello. It's almost like it took a long time. I mean, this is just one example, and I'm not saying it happens with all kids, but I'm trying to just show a point.
It's a nice example.
Yeah. So it is a neural pathway, and without the pruning, the kids do have bigger brains, they say. So they may also present with a slightly bigger head than normal in terms of the head circumference.
That can sort of explain also them being overwhelmed in our world. I think with the sensory input and stuff, that's my perception of them, is that it's just like everything is just too much.
Too much. It's just too much. Yeah. Yeah. So their senses can be heightened or they can be dampened down. So some kids will have a very high pain threshold. You know, they'll fall, get up and go, and you'll only realize, hey, boy, you've got a cut, you're bleeding. But to them, it's not like they didn't feel it. They felt it, but it's just,
There's a lot going on.
There's a lot going on. Or certain sounds where it will bother them. You're not even aware of the sound. We're sitting here, there's a slight lull. It might bother an individual with autism that there's this sound and they'll block their ears. Or, they can have any of the 5 senses. So taste, touch, smell. Some of them smell everything all the time. So, And in our African culture, that can be rude when you get a kid who wants to smell food and then doesn't want the food. You know, it's like
take offense.
Yeah.
Sure. There's just so much, Bongi.
Yeah.
Now there's a word I've come across, I think this year, stimming. Was it stimming?
Yeah.
And I just understand that it's a repetitive behavior. Or can you please explain that? I don't know if it's a colloquial term or that actually is the medical term for this.
So you can use it medically, but we use the word stereotypes. So this is also part of the definition and how we would make the diagnosis. So they can have motor stereotypes where it's movement, either hand flapping, clapping when they're excited, playing with certain objects, moving them up, humming, screaming. It's all part of what they call stimming, which is understanding it. I also don't quite have my mind wrapped up around it yet, but it usually happens when they're either excited, when they're upset, when they're anxious. The stimming can get worse. So I've got many patients who are older and verbal, and when you ask them about the stereotypes that they do, they tell you that I just have to do it. I have to do it.
I can't even.
And then when I'm done, I feel better. Yeah. So that's why I'm saying I'm also still trying to wrap my mind around it. But the patients that I've asked say it's something they have to do. They just do it.
So maybe it's falling on the spectrum of some obsessive, a compulsive thing of sorts.
Yeah, maybe, I'm not sure.
Sure. It's interesting. I mean, I think that, we'll learn more with time and over the years, and because it's not something you can put in a lab and look at it under a microscope.
We can't,
and, so I think these explanations may come with time. And I think different cultures and different countries and whatnot will have different interpretations of all these different things, So, how would you advise a family or a doctor of another family where you're not sure, but you suspect that there is something, because I feel like sometimes you say that a mom will suspect, or a parent, a primary caregiver. But I've also found that a primary caregiver will not. And I don't know if it is I don't suspect, or I don't want it to be that. So I will not see it.
Yeah. So I do think that it is sometimes I will not see it. And I get patients who come to me at the age of 5, and I will ask the mom and say, but mom, your child is 5. They're not speaking. And then she'll tell me, no, the uncle spoke late. My other child spoke late. We were waiting. The grandmother said this. And I'm like, but you as a mother, living with this child, you've got other children, you've seen when the language should come in, and it's more that she was hopeful that it will come. So she knew, and they usually will tell you, the moms, so they'll say that, I had a feeling, but everyone was saying this, saying that, and then they said, no, speech therapy, so I went there. And then we did this, and then we went there, and I've tried everything. But now I'm here because we're worried about school, and this child's not going to cope in a mainstream school. So in terms of advice, it would be, if you suspect, say something. And I know it's hard.
It's so hard.
It is very hard, especially when it's people who are close. Yeah, but there's something important about planting a seed. You'll say it, and that mom might react defensively and say other things, but that seed is planted. It's planted now. And I would like everyone, and I know that it's a tall ask, but if you suspect anything about your child, go and seek help. Ask whoever you're asking at your local clinic, your pediatrician, your GP, and just say, I'm just slightly concerned about 1, 2, 3. You might not get the first doctor or the first nurse or the first person you tell agree with you. And because we are human, we always want to tell people about hope and be hopeful. But I think if you don't get the right answer from the first person you tell, try again.
Try again.
Try again. Yeah.
Yeah, because it's a tough one. I mean, I find even with my patients, like they'll hint like, okay, she doesn't say much, dog. I think she's shy. I think, and then I'll say, okay, but like how many words do they have?
Yeah.
And then they'll be thinking, and I'm like, a 3-year-old, you shouldn't have to think and count words, And then I'll say like, okay, look, I am going to see you guys again. I think let's watch it. And then I think if the next time we come, there isn't much more progress. And then I think let's look into it. We can start, like you were saying, checking the hearing or see if it's just like a speech delay or if there's more to it,
Yeah.
So, but it's very difficult. And then when it's family,
your family is hard.
It's very hard. And especially if you are also a parent, because now it's like you are
comparing my child to your child.
Exactly.
Yeah. But I still think if you care, rather early than later. Yeah. I mean, I've had to deal with it in family as well, and they know what I do. Right. Yeah. So when I say something, I still can't force them to come and see. And I'll say, don't come to me. I'll send you to someone else. But just go and get it checked out. Yeah.
Goodness. And so parents will want to know, right, if they do get their diagnosis. There's that initial thing of like, okay, is it true, is it not? But once they've accepted, then we go back to, but why? Why me?
Yeah.
What did we do?
Yeah.
Did I have my child late? Is it the vaccine? What is it? And so what do you have to say about the possible causes or the misconceptions about causes?
Yeah, so I always go into the cause once I've given the diagnosis. One is parents shouldn't blame themselves. Yes, we may only pick it up when the child is 3, but this would have happened anyway, And what I say to the parents is, I haven't changed your child. They walked in here. You are worried about the speech. All I've done is give it a name. I haven't changed your child. It's still the same child, and now we're going to have a plan of the way forward. But in terms of causes, yes, there are certain causes that we know will put you at a higher risk. So one is if the father is above the age of 50, that increases your chances. If mom's age is above 35, advanced maternal age, that may increase your chances.
Advanced maternal age of the mother.
Of the mother is 35, but of the father is 50.
But so this is interesting. An advanced maternal age of the mother can result in a child with normal chromosomes and normal genetics, they'd say. So we're not talking about the trisomies here. We're talking about, when we look at it, it's a normal number, but still there was something.
Yes.
Oh gosh, what a whammy.
It is a whammy, I know, since all of us are on some, career, kids later, But so the advanced maternal age above 35, advanced paternal age, prematurity. So if you have your kids before they've reached term, their chance of having autism is much higher. Yeah, and then if you have family history, so anyone with speech delays, and it's hard to say anyone with autism, especially in our African context, because the previous generations didn't go for diagnosis. So it's about asking the history. That uncle that you said didn't speak, what were they like? Exactly. Tell us more. And then you're like, maybe it was. So if there's a family history, we know that it's higher in boys than it is in girls.
This is also what I wanted to ask you. So girls can have it?
Yes.
But more in boys?
More in boys. So, if your first child is a boy and they have autism, your next child, if they're a girl, the chance is slightly less. But if the next child is a boy, the chance is slightly higher than if they were a girl. It's almost like being a girl is a little bit protective. in terms of having autism. If your first child with autism is a girl, or you have a girl with autism, then your chance for the next child, regardless of whether they're a girl or a boy, is higher, because
Even
it
higher
means,
now.
yes, the autism happened in a girl, which is supposed to be slightly protective than it is in.
So it's a stronger
Yes.
gene. Maybe it's attached to that X.
Eesh, yeah.
Hectic.
So, yeah. So I think there are other causes if they're genetics, lots of genetic conditions. So if you have those genetic conditions, Fragile X, tuberous sclerosis, Down syndrome, I'm sure the list is long with genetic conditions that can cause autism. And if you have other syndromic features, some of the syndromes aren't named yet, but intellectual disability
There's too many.
associated with it, you can have autism as well. So, yeah, there are many causes, and we try, that's why we sit and take a history for a good 40 minutes to find possible causes.
So besides prematurity, which is usually out of anyone's hands, anything in utero or during pregnancy that can happen or was done that can result in it?
So, I mean, your hypoxic ischemic encephalopathies. So, if you have difficult delivery and the child doesn't come out breathing, if you've had any brain injuries, prolonged intubations, anything that affects that developing brain could also probably result in
basically anything that can destabilize a developing brain.
Probably, yeah.
Probably.
Yeah.
Good
So there are many causes. Yeah.
And then would it be classified, and I can probably already answer my own question, but I want you to explain, as a disability, or how would it be defined in terms of those who do need that assistance? And sometimes assistance equals money, equals medication, equals special care. So who qualifies for, let's say, even the care dependency grant? How do they look at that?
Right. So I think autism itself as a diagnosis qualifies for the care dependency grant.
The whole spectrum.
The whole spectrum.
Okay.
Yeah. I haven't yet had someone that we've applied for the grant and it was denied if they were higher functioning or more verbal. I think that's a good thing in terms of they've accepted that it is, because even if they don't need a lot of support now, they might need the support later on. They still have to attend speech therapy, occupational therapy, may need extra lessons, may need special schooling. So all of that is finances, and it does qualify as a disability. It is an unseen disability in some individuals, where you'll look at the individual and you won't even know they have autism until something happens and then you see all the symptoms, or you have a conversation with them and you realize, oh, okay. So in terms of classifying it as a disability, I think for access to services, it is important to look at it in that way. I did mention the autism advocates who would say, disability, differently abled. Yeah, but I think for access to services and for assistance and inclusion, we've got to say it is, so that you can access the services and be able to get the help that you need. But it is that unseen disability that you don't initially suspect.
And then if it is something that is partly genetic, that you can't, it is what it is, right? We probably couldn't prevent it. What then is the role or benefit of treatment? I hear you talking about speech therapy, occupational therapy. I mean, so you're saying that children with ASD have the ability to learn these skills? And then my next question is, why would they need medication, and what type of medication are some of them on?
Okay. So you ask an important question. The medication that we have is not to treat the autism or make the autism go away or make the autism better. Unfortunately, there is no medication that can do that. Medication usually is to treat any co-occurring conditions or comorbid conditions or other conditions. So individuals may have autism, but then they may struggle with other things. Mm-hmm. They may struggle with sleep. So medication may be, if this child is sleeping at 2 a.m., the whole family is not sleeping. So you want to try and get that child into a good sleeping pattern. Obviously, medication is not the first thing we go for. We always try non-medical management first, and then you'll do medication. So if they're struggling with sleep, if they've got self-injurious behavior, so some of them can be quite anxious and start banging on their heads, hitting themselves. I mean, the child's hurting themselves. So you really would like to reduce that. Yeah, so you're treating that. If they have epilepsy, you're going to treat epilepsy or any other conditions that they may have. Medication is to assist with that. So there is no medication that is going to cure the autism, and not all individuals with autism are on medication.
Okay.
So we have, I think at our clinic, about 60% on medication, and then about the other 40% not really on medication, but still needing the support, which would be the speech therapy, the occupational therapy. So you're asking what's the benefit? It's a developing brain.
Still.
This
Up until what
child.
age is it still developing?
Your brain develops all the way to death. Yes, at a slower rate.
Okay.
But you are forming new neurons all the time. So as you know, there's neuroplasticity.
Okay, wait, for new neurons or new
pathways.
Okay.
But you can.
Okay.
I mean, look at stroke individuals. If you look at it in a child versus an adult, the child will heal, yes, much quicker than an adult will from that, as just giving the example of a stroke. But neuroplasticity, we are kind of still forming these pathways, these connections, and you can learn to form new connections.
Okay.
It's easier for children to learn languages when they're much younger in the first 2 years. But you can still learn a new language when you're much older as well. It takes forever, but
this is good news. So you're saying let's say it's the same child, I clone the same child who has autism, and this one is diagnosed, the same child is diagnosed at 2. One is diagnosed, one is not.
Okay.
One goes for all the therapies, let's say has no comorbid conditions, and the other one, nothing is done.
Yeah.
Mainstream crash, whatever the things that happen to that poor child. So you're saying with support and therapy and other assistance, they will look like different 12-year-olds.
Yes. So early intervention has been shown to improve outcome. I mean, you give an ideal kind of beautiful experiment of having the same child, same genetic makeup. We can't do that experiment in life.
Yeah.
But they've looked at children who haven't had any intervention, compared them to children who've had intervention, and the outcome is much better in those who have intervention than those who don't have intervention, in terms of behavior, how they learn, response, being able to be, slightly independent and even fully independent. Even a simple one is potty training. You know, I always tell parents, you don't need to be able to speak to be potty trained. We can start potty training early. And parents will tell you, I've struggled. You know, this child just wants to do number 2 in a nappy. Like, yes, because you've gotten them used to doing number 2 in a nappy. So now we've got to try and change that. It's much harder when they're older. but it's much easier when they're younger. So the earlier you intervene, the better the outcome, whether it's the speech therapy, the occupational therapy, and to help with daily living. Daily living skills, getting that child just to be able to understand, certain commands.
So we don't say, "Hi, autism, leave him. We can try."
Yes. And I always tell the parents, I'm like, "Why are you leaving him? He's 7. He should be buttering bread." And the mom will say, "He likes noodles, but they washing, Teach him, put it out there, make it into little bowls, and teach him how to do it. He'll do it." They come back after the next appointment. "Your dog, he's making his arm." Like, that is beautiful. Yeah. It's also about understanding the behavior. It's not that they're trying. Sometimes it's the only way they know how to communicate is if I have a tantrum.
Something will happen.
And I'm always like, you've got to understand why the tantrum. Is he hungry? Is he tired? Does he want to change the channel? So it's a lot of work for the mom to understand.
It is. And so, like, just moving a little bit to the social impact of it, in the home. I mean, you'll find that usually there is one main primary caregiver.
Yeah.
How do they cope? I mean, you see more moms who have to love these children. The few interactions I've had have not been pretty. I was so sad, like a week or two ago, where we had a child who is nonverbal, was admitted for something else. I think he had diarrhea or something. And then now he was off the drip and he just needed to drink more water.
Liquids,
and then they'd be able to go home soon. But I think mom was so frustrated because he didn't want to. I don't know. But I just walked in. That lady was clapping that child, hey? Like, but also it now seemed out of character because when we met her, I had met such a warm mom who understood her child. But the way she even swore at him, and then packed her things and walked out the ward. And I was like, something is breaking here.
She's also probably breaking because now they're out of their routine as well. And he's not doing what he would normally do. So we try a lot when we get called, if any of our patients are admitted, to discharge them as soon as possible. If they don't have to have IV antibiotics, do oral at home. Rather bring them in to see them than keep them in the hospital. It becomes a problem. And I know you give an example. I want to give another example. We had a hem-onc patient, so a child who's known with autism, was about 11, diagnosed now with a hematological problem, was admitted, and kept pulling out the drips and even the port was just a problem, and they were trying and looking at the chemotherapy and how everything was working out in terms of his diagnosis. It wasn't a good prognosis as such, and keeping that child there while I was like, here we have to palliate, guys. Let's counsel the family. This child will be better off at home where they understand, because now you're restraining them. You're asking us to increase drugs, to sedate them. It's not helping, especially when the prognosis is not good. So it was a difficult ethical dilemma, but even mom in the end said, what?
He's better off
at home. Give me whatever meds I can give at home. I'll come in all the time. And that's how we landed up managing the patient. But sometimes you have to put the child's needs first.
Right.
Yeah. So in terms of parents, they do need support. On their own or on your own as a mother, it's difficult. One child is like 6 children with autism. So if you don't have a good support network, whether it's family or friends or other mothers, you will break. So we do try and refer to support groups. The patients at clinic, I love it. They form their own support groups, They sit there and they'll even ask about which school is good, which school is, Yeah, then I'll come in, doctor, I also want that school. And I'm like, hi, it depends where you live and is it appropriate for your child? But they do form their own
Networks.
network. And when they do that, it's much better. But I do find they are alone most of the time. And the reason is our communities are not accepting yet. Simple thing, going to church. Lots of parents with children on the spectrum have stopped because the child runs up and down. They want to bang, and then the mother's, hey, mtanako, and you don't discipline your child. And then they'll say, we don't even go to church anymore. Going to a mall, for the child might be a lot, and they'll have tantrums and scream, and then people will swear at you, why are you not disciplining? Why are you not, And
so
yeah,
judgmental.
exactly. So I think it's that. And then you think, you know what, my child must not go to the mall or whatever, must stay at home. But also that's not good for the child.
Right.
Yeah. So we need to increase awareness so that people can accept and
integrate them into society.
Exactly.
Accommodate them. Somebody asked me about home care, so like nannies, right? So you have a child, you're a working mom.
Yep.
Some do go to special schools, but they still come home.
Yeah.
So what should be done for the nannies? Do you think they need to be trained, or they just need to be informed? Because also some people don't tell the new lady that's coming to stay with this child.
That's my child.
And next thing, things are going. And I think that also puts these little ones at risk of being abused.
Yes, no, of course, definitely. I mean, this nanny will think this child's being naughty and then start hitting your child. You come home and there's bruises. But I think it's about communicating and being open and telling them that my child has got autism. Name it, say it. They struggle with communication. They may have behavioral problems, but this is how we manage things. When you go to your therapists, if the nanny can come, that's great.
Take the nanny
with because they're the ones who are going to be with the child most of the time when you're not there. So take the nannies with, explain the medication to the nanny, how it works, so they don't also overdose your children if they have to administer medication. And if you can, include them in the support groups. And I know the therapists do run workshops. So they'll have parent workshops on potty training, how to manage certain behaviors, how to increase communication, feeding, all of it. So the nanny should go with. Yeah.
Sure.
So I think it's important.
You thought an hour was a long time.
Yes.
Believe you me, it's up. And we could still keep going. We really could. I think this is such an important topic. But I think just to wrap up, where can people find you? Can mom just pick up a phone and call Dr. Bongi, or do they have to be referred? What are their options?
All right. So we'll start off. I'm mostly a public doctor. So if they do want to see me, then they'll have to come through the public system. But I do have a private practice that's not mine that I do go to, not often as well because of the time. And it takes so long to see the patients. So I think it's difficult, but you can try Grassroots Pediatric Developmental Center, or you can do Baragwanath Hospital, developmental clinic.
At Grassroots, does the other doctor also see?
So at Grassroots, it's not just me. There is another doctor, actually a few doctors.
Okay.
Yeah, so the appointment to get seen, not necessarily by me, might be quicker.
Okay.
It is expensive because it's private, but in the government sector, the longest is a year. But we do prioritize kids who need to be placed in school, kids who have behavioral problems, and those who need medication. And then obviously the young ones for early intervention. But we do have a system of how we see.
How you And if a little one is hurting themselves, I think they would also
we
go
would
higher
see
up.
that one, very quickly, very soon. So we actually have a day where we just see new autistic individuals. On a Monday. That's our Monday clinic, is just new ASD referrals.
Gosh. I think the work you do is so important. I think this is a growing field of pediatrics that I don't know when we'll catch up, right, in terms of the need.
Yep.
But
we need more doctors trained.
We need more doctors trained.
We need, lots of parents aware. And thank you for having shows like this so that parents can be aware. But the need is great. It's huge. And if everyone's aware, at least they can be kinder.
They can be kinder. Just consider that when you're seeing a mom struggling with a little one who is not listening or whatnot. Yeah. Okay, well, Dr. Bongi,
thank
you. Mbatha, thank you so much. If you found this helpful, please, can you share? Let's get the word out. And then please subscribe to the channel for more informative episodes like this one. And thank you. Like also if you've enjoyed it. And see you next time. Bye.